Dear colleagues, welcome to our monthly dialogue. As usual, will be a very interesting dialogue with a guest from Australia, Luigi Fontana. And I'm grateful to Luigi not only for accepting our invitation, but also because in Australia now is really the middle of the night. So it's remarkable that Luigi is with us in spite of being in the middle of the night. Thank you, Luigi, to be with us. And I remind you that this dialogue is live streamed in X, and then it will be posted in X and YouTube. As usual, we have a large global audience, so please ask questions during the dialogue. You can write your questions in the chat, and we will ask you to ask your questions personally, or we can read your question. Now, this is a very interesting dialogue, not only because we have an important guest like Luigi Fontana, but also because the topic today is extremely interesting, it's fascinating. The title of this dialogue is Moving from the Treatment of Chronic Diseases to the Promotion of Chronic Health, which means how to remain young forever. So Luigi will tell us how to remain young forever. It's a big responsibility. But let me introduce now my friend, Raffaele and Caterina. We are both hosting Luigi. And Raffaele, please, can you introduce our important guest?
Hello, good afternoon here. Good night for you, Luigi. So my pleasure to introduce Luigi Fontana, who is an internationally recognized physician scientist and one of the world's leaders in the field of nutrition, metabolism, healthy longevity in humans. He has pioneered studies on the effects of dietary restriction in humans, and these have opened a new area of nutrition-related research that holds tremendous promise for the prevention of age-related chronic diseases and also for the understanding of human aging. Luigi Fontana is the Leonard Ullman Chair of Translational Metabolic Health at the Charles Perkins Center in Sydney, Australia. And he's also Professor of Medicine and Nutrition in the Faculty of Medicine and Health at the University of Sydney, and a clinical academic in the Department of Endocrinology at the Royal Prince Alfred Hospital there in Australia. Luigi was a senior scientist at the Italian National Research Council, a professor of medicine and nutritional sciences at Washington University, St. Louis in the US, co-director of the Longevity Research Program at Washington University. He graduated from the Verona University Medical School in 1994. There he completed his internship and residency in internal medicine. Also, he received a PhD in metabolism clinical pharmacology from the University of Padua. And after that, he moved to the US, mostly to St. Louis, Missouri, and from there on in several parts of the world, and now has been living for the past few years in Australia. Luigi has published over 150 manuscripts in very prestigious journals, including Science, Cell, the New England Journal of Medicine, JAMA, BMJ, Nature Reviews, Cell Metabolism, Lancet, Diabetes, Endocrinology, Circulation, and so on. And he has been invited to present his work at international conferences at top medical schools and research institutes around the world. And he's the recipient of very prestigious awards from all over the world. Luigi's main interest is really nutrition and health. And I think this, Luigi, is a real paradigm shift. even within the European Society of Cardiology, we are still concentrated on disease. You remember that the logo of the European Society of Cardiology is to reduce the burden of cardiovascular disease. This is not really the entire problem that you are trying to face. Would you please say something about this, Luigi, the paradigm shift that you are promoting?
First of all, thank you very much for your kind introduction, and Filippo and Raffaele. And yes, so again, my interest really is to understand how we can minimize the risk of developing chronic diseases. And what we discovered with the biology of aging field is that many of the common chronic diseases we see in our hospital share a common metabolic molecular substrate. So cancer, cardiovascular disease, dementia, fatty liver disease, diabetic nephropathy, and many others, in reality, they share, again, a combination of metabolic, inflammatory, immune, and molecular alterations that can be profoundly modulated by lifestyle. So, of course, smoking, exercise, nutrition, mental stress. And in the biology of aging field, we are trying to understand what are the mechanisms, what are the molecular mechanisms that, these lifestyle factors are driving disease. And I started, this, say, research journey because I was interested in calorie restriction, because one of my professors, Ottavio Bosello from Verona, basically one day he came and he lectured about calorie restriction in rodents. And I was fascinated by this finding, these animals were living 50% longer, and not only they were living longer, but also they were much healthier, cancer, cardiovascular disease, kidney nephropathies, and dementia, autoimmune disease were prevented or delayed. And so during my PhD, then I said, but there were no data in humans. And even in monkeys back then, in 1999, there were no data. And then, I started to look, for someone who was working in humans, and I found, John Holosy, Professor Holosy from WashU, just received a grant from NIH, a big grant, to study calorie restriction and exercise in humans. I wrote an email to him. I said, look, I'm interested in what you're doing. I was just back from London, where I saw, Albert Ferro is here. I work with James Ritter, Albert Ferro, and at the King's College, and then he told me, why you don't come to work with me? And I left for US, and I stayed there for 18 years.
Luigi, we are interested in understanding also your roots, where you came from, where you developed this interest. Can you tell us? You are Italian in origin, aren't you? And
yes, as you can. Yeah.
Can you explain a bit of your starting phase and really what spurred this interest for nutrition and health?
Yeah, as you have said, I did my degree in medicine in Verona University with Professor Lecchi and Piero Minuz. And then I did my residency in internal medicine, and I spent 1 year in London, again with James Ritter, and I started to fall in love with research. And then when I was back, in Italy, I started my PhD in metabolism, clinical pharmacology. I started to interact with people with professors like Carlo Patrone and others. So I was inspired, by, these strong research methods, trying to understand mechanisms. And again, as I said, when I was, doing my residency in internal medicine, I was kind of puzzled, about, the approach, to medicine, as a doctor, every day going to the emergency, doing, diagnosis and admitting patients to the ward, with diseases that I knew were preventable. We know that cardiovascular disease, at least atherosclerotic cardiovascular disease, type 2 diabetes, stroke, and other cardiovascular disease, and as I said, many other diseases are really preventable, mostly preventable with healthy lifestyle, especially if you start very early in your life, to keep under control, these risk factors. And the beauty of this biology of aging field, as I said, is that, we discovered there are some aging pathways like the PI3, AKT, and mTOR pathway that is really key to regulate the accumulation of metabolic molecular damage, because when you downregulate the insulin IGF and mTOR pathway, you upregulate autophagy genes and proteins, DNA repair genes and proteins, antioxidants like catalase, SO2. You downregulate, cell cycle proliferation pathways, so less cell proliferation, less random mutation, less cell senescence, less cancer. And so I think, this is pretty revolutionary as an approach, because instead of focusing on one single disease, and don't get me wrong, what we achieve, in medicine is fantastic. What we achieve in the last 100 years in terms of pharmacology, surgical techniques, different devices is appalling, and we are lucky that, we have these, at least in Western society, we have these fantastic, if you have a stroke, you have, now a stroke unit with thrombolysis, thrombectomy, or if you have an MI, and you can have, a stent, or so it's amazing, but I think it's unsustainable, because of this epidemic of obesity. Just to give you a few numbers, here in Australia, right now, basically 25% of children that are overweight or obese, so they have a BMI higher than 25. Men and women age 25 to 34, we are up to 57%. And in men aged 45 to 54 is 82.9%. So 83% of Australian men, they have a BMI higher than 25. So this is a tsunami that there is no healthcare system that can sustain. So the idea that, we're going to treat all these people, especially now with these younger individuals, with these chronic diseases, with this accumulation of metabolic molecular damage, because when you have excess adiposity, as you know, especially visceral adiposity, you become insulin resistant. And when you become insulin resistant, you have this compensatory hyperinsulinemia. The compensatory hyperinsulinemia is activating this pro-aging, pro-cancer pathway that is the insulin IGF-1 mTOR pathway, and therefore increasing the accumulation of damage in every single tissue. So it's just a matter of time.
I was always fascinated when I saw the figures, the illustrations of two baboons, one beside the other, exactly of the same chronological age, that looked so different if they were put on a calorie-restricted diet. So is this something that needed really an animal experiment of this kind to be so compelling, to be shown in all its evidence as it was?
Yeah, of course. Rodents are yeast, worms, flies, and rodents are a fantastic model because they are short-lived, and therefore you can easily do, survival, not easily, but at least, you can do survival studies, because right now in 2024, we don't have biomarkers of biological age. So we cannot really measure in a randomized clinical trial yet if an intervention is delaying aging, the accumulation of damage or not. And therefore, the only way to measure if an intervention is extending lifespan, more or less, is doing a survival study. And as you can imagine, in humans, it's impossible. And in monkeys, it has been done in the Wisconsin primate calorie restriction study and the NIA calorie restriction study. As you can imagine, it's super expensive studies because they lasted, the average lifespan of a rhesus monkey is 26 years, and the maximum lifespan is around 40 years. So 40 years, even if they started when they were like, I think 5, 7 years old, it's a lot of years, a lot of NIH R01 funding, to complete such a long study. But as you said, the study from the Wisconsin and NIH study suggests that calorie restriction without malnutrition is extending lifespan and definitely health span. For example, in the Wisconsin study, the monkeys on 30% calorie restriction, they had a complete prevention of diabetes and glucose intolerance, 50% reduction in cardiovascular disease, 50% reduction in cancer, less neurodegeneration measured by fMRI, less sarcopenia, less frailty, and many other interesting observations. What these monkey studies found is that the dogma, when I started to work on calorie restriction, again in 2001, the dogma was that only calories were important, that the quality of diet was non-important at all. I remember I was talking with Ed Mazzoro or Richard Binder, who were basically, the two gurus of calorie restriction in rats and mice, good friends, and that was the dogma. Now we know that that's not true, that the quality of diet and many other factors are also important in shaping these aging pathways and therefore lifespan.
And Luigi, how do you say that this topic of doing a global intervention to prevent many non-transmissible diseases, how does this compare with the current approach that we are mostly using in nowadays cardiology, drugs, devices? Is it only a question of cost that is difficult to bear, or it's a much more fundamental question that you are addressing by preventing the diseases rather than curing them?
Yeah, I think it's a much more fundamental. And, as you know, you don't develop atherosclerosis because you have high cholesterol, high blood pressure for a couple of months. It takes many, 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 many years of decades of high cholesterol, high blood pressure, high glucose, inflammation, and other risk factors for the plaque to develop. Indeed, if you look at the PCSK9, the people who are homozygous for the PCSK9 mutation, basically, they have a much lower risk of cardiovascular disease because, as Brown and Goldstein wrote in those nice review article in Cell, I think, a few years ago, if you start from when you're very young with very low cholesterol, it's like, the Okinawans or people in the Mediterranean countries. If you're born with such a mutation and you have low cholesterol for all your life, basically, the exposure is much less. Instead of with our approach, people, they have, high cholesterol since they are young, and then around 50, then, you start to do maybe some measurements, you find, there is high cholesterol, and then you start to treat them. By the meantime, the disease has already, the endothelial dysfunction with the impairment of nitric oxide production and all the cascade of abnormalities, including lately, we know that clonal hematopoiesis is becoming a major risk factor, an emerging risk factor for cardiovascular disease, for atherosclerotic cardiovascular disease. And if you think about it, this increase in cell proliferation is driven by higher growth factor like insulin, IGF-1, and other growth factors are increasing the proliferation of stem cells in the bone marrow, increasing the risk of a random mutation. There is this beautiful paper you publish in European Heart Journal showing that, they did fMRI in the lumbar spine and in the atherosclerotic plaques, and they found, obesity and insulin resistance, for example, they were associated with an increased bone marrow proliferation and also with more inflamed atherosclerotic plaques, and the volume of the plaques were also higher in these people. So it's I think the approach of waiting for people to knock at our door with symptoms is outdated. and is unsustainable in the future. And so I think we need to change our approach, well, our educational approach. For me, you know, the topics about how lifestyles are mechanistically targeting some of these important metabolic molecular pathways driving cardiovascular disease, cancer, diabetes, and should be taught starting from year one in schools. Progressively, of course, as we do with math, you know, it should be an incremental understanding of this knowledge. And in medical school, I've been teaching in US, in Italy, in Australia, probably 1 hour, 2 hours in 6 years of medical training is devoted to the role of nutrition and exercise in preventing, in a mechanistic way, these chronic diseases. Instead of, as you know, mostly is diagnosis of disease and treatment with drugs and surgery. And then I think, you know, we also need to change how we do primary practice. Again, you know, if you go to the doctor, you go to the doctor, and if you have pre-diabetes of high normal glucose, you should start, you know, immediately, you know, to take action to bring back, you know, you don't wait, you know, for someone to have full-blown type 2 diabetes. Because if you have full-blown type 2 diabetes, it means, you know, you have probably 15, 20 years of pre-diabetes and maybe another 5, 10 years of high normal glucose. That means, you know, that for 25, 30 years, you are insulin resistant, you have compensatory hyperinsulinemia, very high insulin, and other abnormalities, chronic inflammation, increased platelet aggregation, all these factors by secreting PDGF and other hormones are driving colon cancer, they are driving cardiovascular disease, they are driving dementia, arterial stiffness. So it's, you know, you have 25, 30 years of accumulation of damage, and then eventually, then, you know, when someone has type 2 diabetes, you prescribe metformin or the new drugs. It's crazy to me.
So this is a really crucial point. Everybody would agree that having a diet, a healthy diet, doing exercise is the way to go. But many people say this is so difficult to achieve that we need drugs. And now we have the magic drugs that are overflowing in the Western world, difficult to find because too many people are getting them, looking for them. And how do you see the lifestyle intervention versus the pharmacological intervention in this?
Well, I don't think, you know, there is a fight between the two. I think, you know, if you need medication is okay, but, you know, lifestyle has effects that are complementary to medications, okay? They are not, you know, or you do medication or you do lifestyle. I think, you know, depending on the patient, on the people you have in front of you, you know, you should have the best cocktail of lifestyle. So normally with my patient, I start with a lifestyle intervention. And if I see that, you know, in 6 months, 1 year, they don't respond or they respond partially, then, you know, I start with the medication, you know, to have a stronger effect, but not vice versa. And so probably you were referring to Ozempic, to the GLP-1 receptor agonist, you know, yeah. Look, you know, I think, you know, pharmacologically, they are fantastic. You know, we have been looking for many, many years, you know, to have drugs that, you know, they have such a powerful effect in lowering body weight. It's amazing. You know, some of these drugs, you know, you can have a 20% weight reduction that is probably similar to bariatric surgery or close to bariatric surgery. And my concern is that, first of all, when you lose weight with any dietary intervention, and this is kind of in some way a pharmacological dietary calorie restriction, because, you know, you reduce appetite and therefore basically you start to lose weight. You have a number of important side effects. One is that you reduce muscle mass, so you become sarcopenic. And when you reduce muscle mass, you reduce also bone mass. so increase the risk of osteoporosis. The other one is that, we have shown in a randomized clinical trial comparing calorie restriction, weight loss induced by calorie restriction or weight loss induced by exercise. When you lose weight with calorie restriction, you have a major reduction in T3, in the thiodothyronine. Instead of with exercise, similar reduction, 8% reduction with exercise, you don't have a reduction in T3. When you have a reduction in T3, you have a reduction in resting metabolic rate, and therefore you are more prone to weight regain. And that's what happens. Most people, they lose weight, they lose muscle and fat, and then they regain weight, and they regain mostly fat. And so there is this yo-yo cycle that makes them more sarcopenic, so less muscle mass. That is very important for glucose tolerance. Insulin sensitivity is a very important organ for several reasons. And on top of that, there is another issue that, if you are eating an unhealthy diet, now restricted, then, you have calorie restriction with malnutrition. You may end up, with deficiencies in vitamins, minerals, calcium, and many other phytochemicals, and most importantly, vegetable fiber. There are accumulating data showing that a high fiber diet get digested by the gut microbiota to produce short-chain fatty acids like propionate butyrate that are extremely important to modulate the immune system and in modulating inflammation and autoimmune diseases through T17 and other T immune cells. And therefore, I think, the idea that, we're going to treat this pandemic of obesity with these GLP-1 receptor agonist only is, I think we're going to have bad consequences, long-term consequences.
Luigi, you mentioned inflammation as one important phenomenon that occurs when you gain weight and when you eat too much. And can we oversimplify the thing if we say that weight loss or calorie restriction are a way of stopping inflammation or curbing inflammation? Is it an oversimplification, this?
No, it's not an oversimplification. I think, that probably is the most powerful intervention to reduce inflammation. We did a study when I was US. We haven't published yet, because we have a lot of multi-omics data. We are now in the processing or writing the manuscript. We randomize overweight, slightly obese individuals to a Mediterranean diet. I was feeding these research volunteers a Mediterranean diet rich in whole grains, beans, vegetables, fish, poultry only once a week, no refined processed food, no red meat, for 2 months, or control, typical American diet. So they were consuming the typical American diet for 2 months. And I asked my dietitian to clamp their body weight because I was interested to study the effects of changing quality without calorie restriction, without weight loss. First of all, we had to overfeed people 250 calories to keep their body weight constant, okay? But what we found is that there is no reduction in C-reactive protein and many other pro-inflammatory cytokines. So without weight loss, then in the second phase of the study, instead of, we did, calorie restriction on top of Mediterranean diet or American diet, and then, you start to see the reduction in C-reactive protein, TNF-alpha, and other pro-inflammatory cytokines. Instead of, for example, the cholesterol, the LDL cholesterol, markedly reduced only with changing the diet without weight loss. And we have, lots of, we did colon-mucosa biopsy, so we have RNA sequencing, we have proteomics with SomaScan, and so metabolomics. So, we are analyzing now all this complex multi-omic data. But the message is that weight loss, abdominal visceral fat reduction is extremely important, and probably these epidemiological data suggesting that there are anti-inflammatory diets is a epidemiological effect, because in the randomized clinical trial, despite, a nice, again, when we clamp the body weight, but with a high quality diet, we didn't see a reduction in C-reactive protein, TNF-alpha, interleukin-6, and other cytokines.
Do you think it is something that we can preach as easy to achieve, or is it really we are facing the obstacles that we preach, weight loss, calorie restriction, but then the reality is that this is very difficult to achieve, and this is the reason why this the entire nutrition or dietary field is somewhat felt to be less practical than giving drugs. This is the problem I see at the moment.
Look, people like you, like Carlo and other, I don't think, that, you are struggling too much, to keep your a healthy body weight. Of course, diet, as I said, is not the only solution. I think, a healthy lifestyle has to be comprehensive. There is no way, you can keep a healthy body weight only with diet. You need exercise. Exercise in different forms is essential. Otherwise, as you get older, you lose muscle mass, and therefore, it's very difficult. Apart from all the other benefits of exercise, GLUT4 overexpression, BDNF, there are so many other positive effects of exercise that are additive to a healthy diet. But again, as I told you, in this randomized clinical trial I was trying to explain, without counting calories, just by eating a high-fiber Mediterranean-like diet, people were losing weight. So if you have a combination, so we published a paper in Lancet Diabetes Endocrinology, the results of the calorie phase 2 study trial was two years of a multi-center, 220 people randomized to 20% calorie restriction for 2 years or control. And in reality, we prescribed 20% calorie restriction. We achieved a 13% calorie restriction on average. And yet, we had a super physiological improvement in all the cardiometabolic risk factors. So we had a reduction in LDL cholesterol, significant increase in HDL, major reduction in triglyceride, reduction in C-reactive protein, TNF-alpha, urinary F2 isoprostanes, improvement in insulin sensitivity with the OGTT. So there was an improvement in the Matsuda index, area under curve for insulin, significant reduction in systolic and diastolic blood pressure with a 13% calorie restriction with a good nutrition. So 13% is a mild calorie restriction. And then if you combine exercise, it's very easy to maintain. But again, we need to teach from an early age, not only the theory, but also here in Sydney, I have, I'm directing the Charles Perkins Center RPA clinic. I have hired a chef in residence with whom I'm basically developing recipes, and we have a lifestyle medicine clinical service. I have an exercise physiologist, a psychologist, and patients, that have metabolic syndrome. They come to our workshops and they learn how to cook, because, if you tell people just eat healthier, most people have a vague understanding of how to put together a healthy, tasty meal and how to exercise properly. Most people, they think, they know how to exercise, but they don't. And therefore, in my mind, for example, in Italy, as you know, now we are developing these Case della Comunità, community houses, that they should be like a intermediate place where, from the GP, you go to the house of the community houses, to try to not overload the hospitals. Yeah. I think, these professionals, a chef and a dietitian, an exercise physiologist, psychologist should be a crucial part of these community houses. And then the GP, when they start to see, your blood pressure start to be 130, so elevated blood pressure, your glucose is maybe, 95 milligram deciliter, 105. You don't wait, for someone to have, 130 milligram deciliter of glucose before you start to do something. When you have 95, you're already, we have some data we haven't published yet that, with the UK Biobank, that, if you have high normal glucose and you have a BMI of 25 or higher than 30, your 5 years risk of type 2 diabetes is already much higher. So I think that's what we need to do. And it's not difficult if you combine, different interventions together, especially if they are personalized based on your genetic, metabolic phenotype. It's not difficult to maintain a healthy body weight, to prevent the accumulation of abdominal fat. Because again, the accumulation of abdominal fat is probably one of the most important risk factors, because it's driving, as I said, the hyperinsulinemia for many, many years. When you have hyperinsulinemia, you have a reduction in IGF-BP1, BP2, and therefore you have more bioavailable IGF-1 that is a major promoter of aging and cancer. You have reduction of steroid hormone binding globally, so you have more bioavailable testosterone, estrogens that are also promoting certain type of cancer, breast and prostate cancer. You have chronic inflammation. You have, probably clonal hematopoiesis, an increased risk of clonal hematopoiesis. You have so many, factors that, they are driving, many of the common chronic diseases.
Luigi, one of the topics that really attracted the attention of the news was the chronobiology of diet, when people should eat, when people should start intermediate fasting, 1 week per day fasting. Can you tell us a little bit what is real in all these histories, and what is really fashion or something promotion to a certain diet versus another? What is really the truth?
I think the field is still in its infancy, and the problem is that all these studies on intermittent fasting has been done in rodents, and 2 days of fasting in rodents is lethal. So if you fast most strains of mice for 48, 36 hours, they die of starvation. Even people like me and you, we can go for a month. There is a publication of a man who was, I think, 180 kilos, who fasted for 1 year with water and vitamins. Okay, so how long you can fast depends on how much fat reserve you have. But even people like me and you, probably we can go for 50, 60 days without eating. Rodent, 2 days dead of starvation. So when you do intermittent fasting in rodents, in 1 day you eat, 1 day you fast, basically probably it's like 5 days of fasting, 5 days of feeding, 5 days of fasting, 5 days of feeding is impossible. And probably 12 hours of fasting in a human, in a rodent, probably is like 2-3 days of fasting in a human being because of the very high metabolism. So when we started to do studies on intermittent fasting, like the 5-2 diet, other diet in humans, we did a study in US, a randomized clinical trial, 6 months. These people, they were randomized to 2 days of fasting, non-consecutive day of fasting, if the BMI was between 24 and 28, or 3 non-consecutive days if the BMI was between 28 and 35. In 6 months, we achieved 8% weight loss, 16% reduction in body fat by DEXA. So nice, like, calorie phase 1 or calorie phase 2. But the primary outcome was high sensitivity reactive protein, no change. With plexiglass, we measure a number of cytokines, chemokines, no change. There was a trend for increased TNF-alpha. And, when we did, the OGTT and the glucose tolerance and insulin sensitivity, insulin action, where was a minor improvement in only few, I think, glucose at 90 minutes and the insulin, but very, very minor compared to the major effects, of exercise, endurance exercise, and calorie restriction, daily calorie restriction with optimal nutrition. So my sense is that the idea that you just fast or you do the time-restricted feeding and then you keep eating your unhealthy Western diet and you don't exercise is not the solution. So you can lose weight, body fat, but without the metabolic benefits. And let me just reinforce that, there is a beautiful paper, randomized clinical trial published by Bettina Bittendorfer and Samuel Klein from WashU, where they randomized obese women to 10% weight loss. But half of them, they were doing 10% weight loss on a normal protein diet, 0.8 grams per kilogram body weight. And the other half, it was 10% weight loss on a high protein diet, 1.3 grams per kilogram body weight. So similar weight loss, similar reduction in visceral fat by MRI, similar reduction in liver fat by MRI. But the women that lost 10% of their body weight on the normal protein diet had a classical improvement in insulin sensitivity measured with the euglycemic hyperinsulinemic clamp. But those who lost basically 10% on the high protein diet had zero improvement in insulin sensitivity, suggesting that the high protein diet was preventing the beneficial effects in improving insulin sensitivity mediated by weight loss.
So let's be careful about what we choose.
Raffaele, I can read many interesting questions from the audience for Luigi. There is one question from Benedetta Izzi from Antonello Ganao about biological clocks. Are they interesting? Is the future there? Can they become targets, endpoints of trials? What do you think about?
Well, I think that in principle the science is extremely interesting. In rodents, like any of these science, all these genes that are controlling these clocks. We know that many of our hormones, like think about cortisol, they have a circadian rhythm. There are many genes and many hormones that they follow a circadian rhythm. So there is no doubt that it's important. Again, I think that clinically, not for rodents, from human beings, is an additive effect. It's not the solution. Like some people that are trying to sell, you do the time-limited feeding, you eat everything in 8 hours, and then you are fine. You're going to live longer. You're going to prevent diabetes, stuff like, I don't believe that. And there is I think, a New England Medicine paper published a couple of years ago showing that, if you do calorie restriction in one group, basically without restriction of timing, in the other one, I think, they had to eat everything within 10 hours. There was no difference in all of the outcomes, primary and secondary outcomes in this New England Journal of Medicine paper. So in principle, I believe that, if you can eat most of your food in a restricted window, so if you exercise, if you eat healthy food, and you eat it in a restricted windows, in principle is okay. Why? Is because basically then, your insulin for several hours is lower. Okay. So basically, because you are not eating, you don't have the glucose and insulin spikes, and therefore you have less binding to the insulin receptor. But this is not the only, the one size fit all, answer. Some scientists and some doctors, they are trying to sell with this chronobiology. That's my reading of the literature. I may be wrong, but that's my reading, of the literature.
But coming back to biological clocks, do you think that
Yes.
they become surrogates at endpoints, or it's too soon to consider them in our daily clinical practice in designing trials? Are biological clocks ready for clinical utilization, or we need to know more?
I think we need more.
Okay.
I think.
Very well. Then Carlo Patrono raised his hand. Carlo, please, your question. Yes.
My microphone? Okay.
Yes, you can.
So thank you, Luigi, for your stimulating presentation. I fully agree with you that a key point for intervention is very early childhood, and that we should do our best to try and educate very young children about the importance of healthy lifestyle, both on the eating front as well as on the physical activity front. However, this is not simply a technical problem, but it's a political problem. We cannot directly address maternal schools unless we go through the local politicians that regulate what happens in the school of Rome or in the school of Lazio, and eventually in the whole country. So are we not doing, as medical scientific community, enough to convince politicians of the fundamental importance of such educational interventions, or are politicians simply deaf to these suggestions?
No, I don't think they are deaf, because, for example, now this summer I've been discussing with the assessore, so basically the head of the political head of health in Trentino, is one of the provinces in Italy, and they are very open because they are extremely worried. They are extremely worried about the sustainability of their healthcare. They know that, in 10, 15 years, it's going to be a disaster because, with all these elderly, regimented or frail individual with multiple disease, there is no way that, right now in Italy, we have 24% of Italians older than 65, predicted 34.4%. So in 2050, more than one third of Italians are going to be older than 65, based on a publication we did with Vincenzo Tella, is an economist from Tor Vergata in Rome. We had access to the health search database. It's 900 GPs who are electronically entering all the data of their patients. Of these people older than 65, 90% they have at least one chronic disease, and 65% they have two more chronic diseases. Same data are in Australia from the government. So politicians, they are extremely concerned. Some, they are starting to think and they're open to change. I think, the medical scientific community has a huge role to start to discuss about these issues and to propose, different alternatives. And apart from education, we just published a set of pilot data from a trial has been done here in Sydney from a colleague of mine, where instead of doing the classical primary health care, where you go to the doctor, in Australia, the GP is a fee for service. So basically, the more patient you see, the more you earn. So typically it's a 10 minutes time, to see one patient. And so he with philanthropy, he was able to try this new model where it's called value-based, less patients. There was a doctor, a coach, a health coach, and a nurse, and they were proactively following their 6,000 patients. There were 3 clinics. Basically, after 3 years, there was a 51% reduction in hospitalization. 51. So we have to repeat this trial. It was just a pilot, not probably precisely designed, but even if it's a 30% reduction in hospitalization in 3 years, we estimated that this is, for these 6,000 patients, is $9 million saving per year. On a national scale, it was billions of dollars saved that could be reinvested in educational, healthy food. I was reading yesterday that, in US, they are proposing to make, Ozempic, the GLP-1 receptor agonist, basically paid by Medicare, is $1,500 a month for millions of people. With $1,500 a month, you can provide healthy food and a subscription to a gym and educational programs. Is much cheaper. And I think, the long-term health consequences are much better than just losing weight and become sarcopenic, maybe with dysbiosis and vitamins and mineral deficiency.
Thank you.
We have one more question from Riccardo Proietti. Riccardo, please, can you ask your question? Amelia, let's unmute.
Hello?
Yes.
Hi.
Can you hear me? So first, thank you and congratulations in this nice presentation. I'm keen to ask about I don't know if this is the proper terms, but health effect, in the meaning that we have shown, it has been shown that lifestyle changes are enforced by the intervention on the environment, and there are lots of studies on why the environment intervention, showing that intervention in the city, changing where the people lives, enforce the adoption of healthy lifestyle. And actually, this summer, we were submitting a proposal for a cardiovascular prevention EU grant, 5 cities that you may have heard about. And my partners were insisting on this effect in this index, in developing this index and considering the health effect. So if all the of lifestyles, if I live in a city where all the population is behaving and is doing a good nutritional scheme and physical exercise, I'm forced to do a good nutrition. And but this to me was quite elusive, and I don't know. I ask even if they have reference on that, or if this effect has been sized, but they couldn't provide. So I was keen to ask you this and get your opinion. Hope my question is clear.
Well, I hope I understood your question well. Yeah, I think that of course if you live in a society, let's look here in Sydney, if you live in the affluent area of Sydney, like the eastern suburbs, northern beaches, the percentage of people with overweight, obesity, and chronic disease, it's much lower, and people, they live 15 years longer than people living in the western suburbs, where there is, they are less affluent, they are low SES. And you, as soon as you go to, this Manly Beach or Bondi Beach, people there, everybody's running, they play football on the beach or volleyball, there are more options for healthy food, healthy cafe, and so people, they imitate each other, of course. If your friends are not smoking, they are not drinking, they are eating healthier, and there are availability of healthy restaurants and people that are running, exercising, they're biking, you are more prone, to exercise and bike if you instead of, and that's why, for example, in Italy, in South Italy, like Campania, Calabria, Puglia, the rate of children obesity is close to 50%. 50% of children in Campania, they are either overweight or obese. In Val d'Aosta, I think is 8%. In Trentino, is like 12%. So we are assuming that, people from Trentino, they have a different genetic background from people from Naples. No, this is just environmental factors, people that are following the same rules, eat, no exercise, and lack of facilities, swimming pools, bike trails, and so it's definitely a social, and that's again going back to what Carlos said. I think physicians and scientists, they have a huge responsibility to discuss with politicians how powerful these interventions are, so that as doctors and specialists, instead of being overwhelmed by a tsunami of unhealthy patients that makes our life impossible, then we dedicate our time to work on these unlucky people that for some reason they develop a disease, and then we have the best treatment ever to help them to regain their health or increase their lifespan and health span. Instead of, I think, we are going to become overwhelmed. We are already overwhelmed. I mean, think about in US, 10 years ago, the healthcare cost of based on CDC data was $3.2 trillion. Last year, it was $4.2 trillion. So in 10 years, there was an increase of $1 trillion in healthcare cost in US. and life expectancy declined by 2.5 years. 80% of Americans that are over or obese. One in five have type 2 diabetes, and 1 in 3 has pre-diabetes. I don't know how many they have fatty liver disease and diabetic nephropathy. It's a disaster. So, you spend $4.2 trillion with these results. So these tell us, that, the idea, is just spending more in healthcare is going to make people healthier. The US is the clear example that is not working.
Luigi, we have really several interesting questions from the audience. One comes from Jean-Pierre Desprez. He congratulates you for your excellent work and leadership, and he finds the Osana trial particularly interesting. Can you tell us about this Osana trial?
Yeah, as I said, this is a pilot trial that has been done by Kevin Cheng here in Sydney. A friend of him is a very wealthy guy. He gave him $10 million to start this experiment where basically they opened 3 clinics. And as I said, instead of doing the fee for service, they paid the GPs salary, and there were incentives for the GP if they were basically achieving results in terms of improvement in several metabolic parameters, reduction in obesity, BMI, more physical activity, reduction in blood pressure, cholesterol, glucose, and other parameters. And also there was an incentive for the patients who were achieving their goals. Basically, these GPs, basically, they were screening their patients. They were seeing if there were any problems, even early problem, and they were proactively with also a gamification. They developed an app where they could follow patients proactively with goals. And if someone was not achieving the goal, the health coach was calling them, look, come back. And there was a facility with a exercise physiologist, a centralized facility for these 3 clinics with exercise physiologist and a gym and some healthy cooking workshop, a dietitian, a psychologist. And as I said, in 3 years, because of this proactive, preventative activation type of primary health care, they achieved a 51% reduction in hospitalization, improvement in many health parameters. And but again, I think this is one study. I think I'm actively trying to lobby the government to give me some funding, because this study is going to cost, I think, in Australia $15 million if you want to do properly with a control group and have well collected data to repeat this experiment in a low SES, because this has been done in a kind of affluent area of Sydney. So it will be interesting to see what happens if you do it in a low socioeconomic area of Sydney, and see if what type of result you achieve, how many reduction in hospitalization. And the problem here in Australia is that, I don't know if you're aware of, the federal government is funding the primary health care, and the state government is funding the hospital care. So the two systems, they're not communicating. So basically, what the federal government is funding is not of interest of what the state is funding. And that's why, basically, unless, you unify the system and say, okay, if you spend a bit more in primary health care, you're going to save a lot of money for the state, then I think, the system, but we need to revisit, how the spending, the healthcare spending is subsidized and distributed in a different way. So it takes, some data, more nice data, and then, with this data, you calculate how much you save in hospitalization. And as you can imagine, if you have a stroke, or if you have a heart failure, if you have a myocardial infarction, the costs are huge compared to prevention.
Luigi, one of the questions that came from the audience is, I think, is very pertinent to what people should really put their effort in. How to convince politicians to include more lifestyle therapy into medical care. And do you have a simple answer to this question?
Well, with the scientific evidence, with experiment like Osana, that I think, they should be repeated in Italy, in other. So in different population, we have to calculate how much you save if people, they are doing what you and Carlo and me, we are doing. So how much you save, if you avoid, obesity, if you keep, if you do your exercise regularly without, being extreme, because you publish excellent papers, in the European Heart Journal, demonstrating, people who are overdoing exercise, they have damage. Exercise, like any other intervention, if it's extreme, is causing myocardial fibrosis, increasing atrial fibrillation. There are a lot of damage if you are overdoing exercise. And there are some people that, they think, the more they exercise, the better. That's not correct. And hopefully also we're going to develop biomarkers. We badly need, biomarkers to understand what is the optimal caloric intake for you, not for the general population. What is the optimal protein intake? There are beautiful data showing that, moderate methionine restriction or tryptophan restriction or isoleucine restriction is extending lifespan in rodents. So, and there are human data, again, suggesting, these essential amino acids, they are regulating the mTOR pathway that, as you know, is a powerful anti-aging pathway. If you give rapamycin to rodents, even when they are old, they live longer. You extend the lifespan with a drug that is rapamycin that is blocking the mTOR pathway.
Well, Luigi, it has been really a wonderful dialogue, wonderful conversation. I come to the title of this dialogue, moving from treatment of chronic diseases to promotion of chronic health. And I think that what we have shown today is very clear. This is possible to remain young, not forever, but for a long time. And perhaps it's simpler than we believe. The right amount of exercise, the right amount of food, the right choice of food. These are three things which are not expensive and can promote really chronic health. My last question is about the hurdles. There are, of course, hurdles. We discussed some of these hurdles in the transition from treatment of chronic disease to promotion of chronic health. But in one word, what is the main hurdle? Inertia, politicians, what else? Lack of knowledge, the major hurdle to promote chronic health.
All of them.
All of them.
I think, we need to act, on multiple. It's like, we publish, on your journal in CardioPulse, these 10 points for a healthy cardiovascular, healthy longevity. There are 10 points. And, for example, in this, let's say, dialogue, we didn't discuss about mental stress, emotional health. It's very important, extremely important. We know that, through AC5, AC5 knockout mice live longer and they have less cardiac disease and cardiac fibrosis because AC5 is the transducer for catecholamines. So if you have excess catecholamines because you have mental stress and other issues, you're activating a pro-aging pathway. So it's a combination of factors that are shaping this metabolic molecular substrate that is leading to multiple chronic disease, and to change the system from treating chronic disease to promoting chronic health, we need multiple approaches: political, the medical scientific community, the education, and changing the primary health care, changing how we educate people, community work with non-organized NGOs. And so there are a lot of different points of action that, we need to go
Luigi,
to do together.
In this setting, can we promote coffee? Good signal.
Look, the epidemiological data on coffee looks healthy. All the data have been published from the nurse health study, physician health study, and other major epidemiological studies suggesting, that coffee it's associated with health, but it's, of course, association studies. Is not. I haven't seen a randomized clinical trial, showing that, that coffee intake has beneficial effect. But epidemiological data suggest, that it's good.
And Mendelian randomization are not so positive either. So okay, but anyway, the association is there. What about a glass of champagne? Can we celebrate tonight with a glass of champagne?
Look, the problem with alcohol, as you know, is that there is this weak association between moderate alcohol intake and the cardiovascular disease. The World Health Federation published, I don't know if you saw it, published like a executive summary saying that that's not true, that, basically that probably is a weak association, and definitely alcohol intake is increasing the risk of atrial fibrillation and flutter, is increasing hypertensive cardiovascular disease, and definitely there are multiple data showing that for cancer, there is no safe dose of alcohol because alcohol gets metabolized to acetaldehyde. That is a major carcinogenic, teratogenic substance. And therefore, alcohol, I think, is like smoking. I believe, I don't drink no alcohol. And if you choose to drink alcohol, I think it shouldn't be every day. So the idea, alcohol contains resveratrol, that is anti-aging, is just pure marketing. I think, that alcohol, if you decide to consume, should be, if you go for dinner with a friend, you want to drink a glass of good wine, is okay, but not on a regular base, on a daily base. That's, what most of the accumulation of data are suggesting. Ethanol is cancerogenic and is increasing DNA damage and therefore cell senescence, probably promoting also clonal hematopoiesis and many other stuff, and including atrial fibrillation.
Negative effects on dementia, apparently.
Dementia as well. So there are multiple reasons why alcohol, at least, regular alcohol consumption is not good.
Then let's take to coffee, where the association...
Yeah, let's have a cup of coffee.
Is positive.
Yeah.
We are at the end of this wonderful conversation. Thank you, Raffaele, for joining us.
Thank you, Filippo.
For this wonderful dialogue. And thank you, Luigi.
Thank you very much. It's been very...
We are in the middle of the night. Again, thank you for your participation. And also for the bottom line, for the message of this really encouraging dialogue. There are ways to promote chronic health. It's perhaps simpler than we believe, but there are several hurdles we must overcome. And this allows us to remain young, not forever, but definitely for a long time, perhaps simpler than we've been thinking for many years. Okay, thank you very much. I remind you, our next dialogue will be a very special dialogues, will be on Thursday, on December 26th, will be a Thursday as usual, but will be the day after Christmas, will be a very special dialogue, a very special day. And the dialogue will be with our lady editors, and we will review the important papers published in the European Journal in 2024. Will be entertaining and useful as usual. For today, thank you very much, Raffaele, Luigi, all the friends in the audience, and please remember that there are ways to remain young. One of the ways is to drink a bit of coffee. Bye-bye.
Thank you. Bye.
Goodbye.
Bye-bye. Bye.